Um, Thank you for recording. This is our second series in Return to Care for this year. And we have some special guest speakers. So we're looking forward to the presentation, and I'll turn it over to Oscar and Sonia if you have a few words.
Well,
yes. No. Yes.
Please.
Good morning, everybody. Thank you for joining us today. We're definitely excited and grateful for all our presenters. And Oscar, I'll turn it over to you. Very proud of our CQM team and all the work that they've accomplished. You know, we couldn't do it without all of your support, as well as our team. So thank you again. And I'll let Oscar also share some information for you.
Well, I mean, we are so glad to have the support we have. And that's part of the infrastructure. That's a very strong message across the region. Without infrastructure, you are not solid. So thank you guys, because you are the stars. You're doing this possible, and this happened because of the subrecipient and our consumers. So thanks so much for being here, and we get ready.
Oh, Michael, are you wanting me to advance the slides, or will you? Perfect.
Regina won't be here. Regina is sick today, so I think she's not.
Yeah, that's okay. Well, we are sending her love. This is just a quick refresher, again, with some Zoom info. I think the main thing is just to have your line muted. When you do want to talk, we welcome that. So feel free to unmute or even tickle us in the chat. We've got folks watching the chat, and we want to respond to everything, especially if you have questions for our presenters. We can go to the next slide, please. So here are our learning objectives for our time today. What do we want to accomplish while we're here? We want folks to be able to list 2 changes to our HIV policy environment that have taken place in the last 2 years. Been a lot going on, so we want to give some space to that. And then we hope folks can name 2 new partners your organization can work with and can work into your QIP that you haven't already meaningfully worked with to date on the project. And we're going to hear some examples from Tarrant County on some great cross-agency collaboration. We hope you can describe the process used by 2 area provider orgs to share clients and information in a way that efficiently achieves together, right? So we're creating alignment also with those different initiatives. And then last, we have Dhruvi, Amelia, Miranda, and some others who are going to be speaking to cultural humility. So to be able to explain the relevance of cultural humility and justice as a driver for EHE in the Dallas area, keeping in mind the common thread line it has with our Return to Care QIP. Next slide, please. So y'all, we don't do this just online, baby. We have a toolkit. So these are the different little ingredients for your toolkit. Everything is already up on Glass Cubes. So we will provide the slides and a link to those materials. It includes not just the slide, but also PCN 2102, which will cover the National HIV/AIDS strategy, which has been updated. We have an action plan form we'll talk about here in a moment, and many other pieces. One of the other things I want to note is that these different articles, what's interesting is it's going to relate to our conversation today about cultural humility and how that actually is involved in our Return to Care efforts in our QIP, and really showing how cultural competency has been a framework that we all are maybe really familiar with. And as the world advances, we advance in our understanding. And so cultural humility is sort of the next level to that, and thinking about the practice of applying those competencies. We know a lot more now about privilege and what it means to have privilege. And so we want to integrate those pieces and themes into your work to support your QIP efforts. I believe I'm going to turn it over to Angie.
Hi, thank you. Good morning. This is just a slide. We wanted to just kind of have a refresher of what our time period looks like for this year. And we want to make sure that we begin to get in the habit of working on our action plans in between our sessions. So each box with a date is one of our training sessions. And so the spaces on each side represents action period. So we want to be working actively on our action plans and focusing our efforts during that time frame in between our training sessions. So this is what we're calling the action period. And our expectation is that the subs will make progress between the sessions using the action plan templates. The next slide, please. And so here are some important dates that we're just going to quickly go out over. I know we've had a lot of confusion because we've been switching, trying to get fix our last template that we had. And so there was some confusion with reporting dates and due dates. And so we are all on one accord now. Regina sent out the last one pager, I think a couple weeks ago. So on June the 1st, August the 1st, and October the 1st, we have the QIP forms, the PDSA worksheets, and our action plans that are due. And it's really important. Let me stop for a second. So, and then in December the 1st, we'll have the QIP reporting form, the PDSA worksheet, and the poster presentation. So if you notice, the dates coincide with the training sessions that we have. So at the 1st of the month, the reports, the forms, whatever it is, that the action plans are due. And then we use those because they flow into our training session that happens later on that same month. So this month, this time we only received about 3 action plans. And so that caused us to have to pivot a little bit. We wanted to include some of that data in today's session, but we weren't able to because we didn't have everything. So next time we may just kind of move forward with what we have from whichever subs who have submitted. We're still working that out. And I believe Michael is up to you next.
Great, thanks so much, Angie, and thanks for reminding us of how we're trying to document and move forward all together. So I'm going to provide a 5-minute overview of something that's very near and dear to my heart as a person living with HIV, the revised National HIV/AIDS Strategy from 2022 to 2025. It is a very, very big document that has a lot of information in it, which is why we've included it in your toolkit. Please take a look at it if you haven't taken a look. It's very exciting. There are 4 goals that are included. The 3 first goals are the same 3 goals that we've had in the National HIV/AIDS Strategy going back for many years since its initial one in 2010. But the 4th one I think is really important. The 4th one we've implied substantially over the course of like the past 2 plans, but it's wonderful to see this distilled as an actual concrete goal in this iteration. Achieving the integrated coordinated efforts that address the HIV epidemic among all partners and stakeholders. And they also clarified for this iteration of the National HIV/AIDS Strategy, the goals are both for federal and non-federal stakeholders. That means that for us as the AA and for all of you as the subrecipients passing through as well, it even means for those of us in our networks that are not even funded. It's very important that this is meant to be an overarching collaborative framework for us to think about how we can actually make a difference here. I want to just spend a moment on dangling this in front of you to look at a couple of key items. This is actually from the Explainer blog post from hiv.gov. You'll actually see this within the plan itself, but this kind of summarizes some of the high points we have within the plan. So number 1, recognizing that racism is a serious public health threat. Yeah, wow, that's really important to have that level of recognition and appreciation for how problems are intersectional and build off each other. Important roles of harm reduction and syringe service programs. Now we know that in our environment we have some sticky points with some of these issues, but I think it's really important for us to look at what we have here and the support we have from our federal partners in the National HIV/AIDS Strategy, and try to think about how we can bring this back to our own shops, how we can agitate or advocate gently and appropriately depending on our roles. Some of us in our roles can't do any of that, and that's part of how the system is set up. But for many of us in our roles, we can. So why not make different calls? Why not do what we can do individually, organizationally, working with your consumers to get your consumers to be involved in some of the activities that we really need to have happen if we're going to be able to achieve an end to the epidemic. Here are a couple of more things that really excite me. And some of the things that excite me the most about this particular set is the inclusion in research. We've talked a lot before about how the clinical research elements have oftentimes been of, by, and for a white male crowd, so the democratization and expansion of inclusion for clinical research to include more people, But for me, some of the things that are the most exciting are the social determinants of health and our embracing of big data. And some of us are really starting to do that. I've heard that some of you, from a recent OA, one of our organizations started using Tableau, and that has really opened a lot of doors for them. So we don't really have time, again, in a 5-minute overview to dive in deeply on any of these things, but this is really just meant to, help expose you to the sense that this is a very new day in the level to which the federal government is embracing the baseline problems in society that are driving the epidemic. And we're no longer ignoring those problems, which I think is very, very important. So other things just to highlight really quickly, there are 4 goals that encompass 21 objectives that cover 78 strategies. Seriously, there's a strategy for everyone here. There's multiple strategies for everyone here. When I read the document, I couldn't help but to keep standing up, like it took me to church. I really recommend that you read through this document and have a sense internally, a conversation about how the strategies and objectives align with what you're trying to do in your vision and mission, and specifically how you're trying to enhance your vision and mission through quality projects like return to care implementation at your sites. There are 9 core indicators that our federal partners are using to actually check in on our progress in this strategy, and are also evaluation factors for ending the epidemic, of course, because these 2 things are very closely related. It's important to note that all of these are over a 2017 baseline. It's important to note that a lot of these are very aggressive too. One of the things that's really touching to me and important to me thinking about equity is that increasing viral suppression to 95% isn't just an overall, and it isn't just among the highest group. They want all 5 of these key populations listed to achieve 95%. Yes, that is amazing. And it's going to be very challenging, and as we know, our key populations for our region actually are pretty closely aligned with the 5 key populations we see at the top of the page. MSM of color, but also more broadly, gay, bi, MSM, males, Black women, transgender women, folks aged 13 to 24, and people with injection drug use. These are the suitcases, basically, or the toolkits that are being promoted by our federal partners in both the CDC and HRSA to help us drive this plan. Again, we don't have a chance to really talk about this, but I'm trying to basically hit you over the head with a suitcase to get you to think about, looking into this more deeply with your colleagues at a later date. And finally, I'm just going to mention that, this plan is really built on many, many, many decades and lots of person years, person centuries of, experience, love, dedication. And in particular, we wouldn't be where we are if it wasn't for the provider community, the policymaker community. But in particular, we wouldn't be where we are if it wasn't for the consumer community and the broader HIV community from which we arise. So that was just a really quick overview of the new National HIV/AIDS strategy. And I'm going to kick it over to Jamie to talk about PCN 2102.
Thanks, Michael. And I love me a cheat sheet. I love a visual, and I hope folks take some time to explore that in the toolkit. Something else we want to bring to your attention, which folks are maybe already aware of, but policy clarification notice, PCN 2102, right? So this is a pretty major shift, and this is looking at determining client eligibility in payer of last resort. So this is going to replace PCN 1302, which folks know as client eligibility determination and the recertification requirements. So key thing here is this eliminates the 6-month recertification requirement and replaces it with allowing our Ryan White HIV program recipients and subrecipients flexibility to conduct timely eligibility confirmations. I believe we intend to hear more from Julie in the state on some of their perspective and some guidance there. So again, this is sort of a high level update reminder, something to definitely take a mental note of if you haven't already begun thinking through it. Another key piece is that it states very affirmatively that immigration status, it's irrelevant for the purpose of eligibility for Ryan White services. So I know Joni has raised her hand. Go ahead.
Hi, Jamie. And forgive me if I missed something, but you are aware that we could not implement this in our EMA because most of us receive multiple sources of funding, and this only applies to Part B. And so I just wanted to clarify that. This would be great because it takes the onus off of the clients to report no changes on an actual form when they don't have changes for their attestation. But unfortunately, the county and the state couldn't come together and agree to do this across all funding sources, I think because of some THMP things or issues, but just wanted to let you know. So most of our agencies, I think with the exception of one who does not receive Part B funding, cannot really use this, and it doesn't benefit us in any way. So just sort of wanted to put that out there. It's great on paper, but it doesn't work in the community if you can't implement the recommendation. So just wanted to put that out there. Thank you.
Thanks, Joni. And I think with all PCNs, implementing is always one different thing than when the clarification comes out. So really, again, we did just want to share this as a potential for additional conversation. And, you know, I think we do still want to have Julie come and share, and if it also becomes a point of advocacy, or, you know, what can we do or how do we make this work, or also understanding, again, just what all the different parameters are. I think you make very good points. I think we can go to the next slide.
Yeah, and just, you know, to put on my cranky consumer hat for just a second, I think that one of the pieces that's really important here is that that's one of the ways that our federal partners are trying to live the national HIV/AIDS strategy that's been revised. These things were being kind of like developed, you know, all together. And the community's tirelessness is what's helped to bring us to this point. And so whatever we can do collectively appropriately to our role and our position within the field, I think is really important to keep, you know, ringing bells, poking buttons, you know, sometimes, you know, making noise about these things that are actually having very, very real effects on our clients' lives.
Mm-hmm.
You know, like, and yeah, I don't know. I think that we have to wait to hear in future sessions how some of those conversations happen, but we are trying to make sure that those conversations are happening because we got to have them happen.
Right.
So I appreciate that very much. And I'm sorry to blather on. At this time, I'd like to introduce Caitlin, or do you want to introduce them? Jamie, sorry, I'm talking.
Oh, no, that's okay. That's okay. So again, we just wanted to highlight again some large policy changes. And now we want to move into sort of the second phase of the webinar series for today. So we're going to hear from Caitlin Lopez in neighboring Tarrant County. And I will actually turn it over to her to share any level of introduction and to go ahead and move us through the slide deck. And just, we really appreciate having you here and sharing your experiences so we can maybe, you know, steal shamelessly where we can.
So yeah, thank you, Michael and Jamie and everyone with Dallas. It's a pleasure to come speak with you. And I have to say, Michael and Jamie, you make some excellent points. I know 2102 has definitely been a battle, but it is we are constantly bugging the state, reminding them that this is a HRSA PCN, and we are here to help service clients, not create more barriers. And so we have definitely been consistently in all of our monthly meetings with the state, reminding them that these are just natural phases that we have to go through. And so hopefully, like you said, that advocacy, and the louder we get, the quicker they'll be able to, you know, find better solutions to implement that. So hopefully for the future. Okay, next slide. And then for everyone, my name is Caitlin Lopez. I am with Tarrant County Administrative Agency. So we are right next door in Fort Worth. I see a lot of familiar names, so I know a lot of you already, but we're excited today to talk a little bit about our administrative agency and how we work with our subrecipients. And then we have two subrecipients, JPS Healing Wings, which is a part of the largest hospital system out here, with where oftentimes a lot of our clients are diagnosed in the emergency room. And then a newer organization that came to the jurisdiction, I believe in October 2020, Can Community Health, is just making waves here, and we're really excited for both of the agencies to share some information with you all today. A little bit about our program. As you guys all know, we are the administrative agency, so we have Part A, we get passed through from Part B, we have C, D, ending the epidemic, HAPWA. So we administer all the funding, but we do not service any clients out of our office. We are simply the administrative agency, and we have 7 agencies that are subrecipients from us. Next slide. All right, so some of the successes that we really wanted to highlight is with our contracts. So here at the administrative agency, we believe in a lot of transparency. In order to create a full system of care, our contracts are pretty robust. That goes with CQM requirements. So for example, we outline exactly the expectations, but then we provide a lot of autonomy to the subrecipient agencies to make those decisions. But at the administrative agency, it's kind of our role to take some of that burden away. So we may start the collaborative, like for example, Create Equity or Prims and Proms, and then we pass it on to the subrecipients to say, hey, here's the framework, here's the structure, here's the resources. How do we help you guys implement this? And then you guys can decide, the specific activities or interventions you choose to get the outcomes from that quality improvement activity. And that goes not just for CQM, it's for financial, programmatic, administrative. So really having a very transparent expectations throughout contracts, and then allowing subrecipient agencies to really have that autonomy and be included in all of the projects. And then communication. So we just wanted to quickly highlight, because I know we have a short time, but communication with all of our subrecipients is super important. So the administrative agency actually meets one-on-one with each agency every single month for about an hour. We run through financial, programmatic, administrative, CQM data. We go through challenges, successes, we look at performance measures, and it really helps us all just be on the same page and work towards a singular mission. Next slide.
To your Gmail account.
All right, so, and I would like to say every image that you see here are people living with HIV from the jurisdiction. Early last year, we did a photo shoot of people living with HIV for ending the epidemic. So these beautiful models are all people living with HIV in our jurisdiction. It's really important for us to create that impact. So referrals, we have what's called Provide Enterprise. It is our client level data system. And we have a singular eligibility system. Renee Thomas, who I'm sure some of you may be familiar with, and Lisa Mutaya, they're great resources. So if anyone has questions on that, feel free to reach out to them. I can put their contact information in the chat, and they can talk to you a little bit about the challenges, but also a lot of the successes that we've had, especially with the rollout of TCT. By having our Provide Enterprise system, it has helped kind of ease some burdens that came when TCT came. And I know I'm a little over, so I'll flip to the next slide. All right, so we did also want to share 2 different cultural humility trainings that we've done recently. Gilead has been a great resource for our jurisdiction. They have a lot of free trainings that they can provide. Trina Scott was absolutely phenomenal. She came in and provided the training with James Berglund. They were able to not only present to the administrative agency, but all 7 subrecipients. We made it just, again, part of our contract language, mandatory training. And then all of the subrecipient agencies sent their staff to attend these different trainings. The Gilead training was 3 days. We spread that out. And then Leisha McKinley Beach came more recently this year and provided 2 separate trainings, which were absolutely phenomenal as well. So lots of really great resources. Next. And then technical assistance. So the AA provides technical assistance frequently on a monthly basis, sometimes for subrecipients. We've asked for technical assistance through CAI for ending the epidemic. But then also from additional sources like the AETC. And then we also provide it for the community. So we have a community advisory board. And we do additional other community trainings on HIV and Ryan White. All right, so then I will turn it over to JPS Healing Wings. We have Eve and Danny here to talk a little bit about their program, working with us at the AA, and then a brief bit about Rapid Start as well.
Hi, everyone. My name is Danny Cameron. I'm the project manager at the JPS Healing Wings Clinic in Tarrant County, and we are one of the subrecipients of Ryan White funding. So I'm going to start out by talking just a little bit about communication between us and our AA. So as Caitlin mentioned, our AA provides multiple scheduled opportunities for us to communicate with each other, as well as for us to communicate with the other subrecipients in our jurisdiction. First, like Caitlin said, we have our monthly hour-long one-on-one meetings with our AA. And with those, we go ahead and we submit an agenda with all of the things that we'd like to discuss ahead of the meeting. And then we use that time to address all of our agenda items, ask questions, discuss contracting, planning, quality management, basically anything that we need or want to discuss. So it's a really good use of our time. And then the AA also uses this time to provide us updates on where we are with our expenditures, share any announcements, etc. And aside from that scheduled time, we of course reach out by email and phone as needed, and we always receive really quick responses from all of the staff at our AA, often within the same day, sometimes within the same hour or a few minutes. So it's really great to have that open communication channel. And anytime that we request assistance or a quick meeting or help with brainstorming, they're always very willing to help us set up those meetings expeditiously. So we also have brief monthly meetings with the quality team at the AA to review our progress on any caps that we're working on as a result of monitoring outcomes. And those are usually really quick, about 15 minutes, 15 to 30 minutes, depending on what we need. And during that time, we share the status of our interventions that we're using to improve our outcomes. And if we aren't progressing fast enough, it's a good opportunity for us to ask for TA, to brainstorm other ideas, and the AA gives us, suggestions or, finds us resources on things that are working for other agencies. Finally, we attend a quarterly quality meeting with our AA and the other subrecipients in the TGA. So as a TGA, we're working on a CQII project that aims to improve viral suppression in Black and trans women aged 18 to 39. And this has been a really good experience for us because like Caitlin mentioned, we were offered a lot of autonomy. The AA didn't just tell us what our role would be in this intervention. At the beginning of the initiative, they gave us a list of about 50 different activities that we could choose from. So that's where we had that balance of, we were given ideas, but we were also allowed to choose from the ones that we felt that we could effectively implement at our agency and carry out. And that would work for us without, making too much change to our programs or being too burdensome to staff or whatnot, but still able to achieve those outcomes that we are looking for. And then we send quarterly updates on the status of our activities to the AA, and we also meet quarterly as a group to share updates, receive TA, and discuss anything new that's related to quality in our TGA. In terms of communication with our other subrecipients in the jurisdiction, we also have quite a few opportunities where we collaborate there. So first, our AA hosts a TGA-wide care coordination meeting every 2 weeks, and that's open to all of the staff at any subrecipient agencies. So during that time, we're able to provide other subs with updates from our agencies. I think it was especially important during COVID when we were, notifying of changes to hours of operation, staffing, all of that. And we're able to share resources, and often we have a presentation about new resources that may be available in the community to help our clients. And then Caitlin mentioned this briefly, but after things began to return to normal after COVID, or we're still in COVID, but we all felt a little disconnected from some of the staff at other agencies. We hadn't seen each other in person in a long time. So our AA hosted a TGI-wide conference, People Plus Purpose Plus Power. It was a full day, and we were able to meet the new staff from other agencies, re-meet some of our colleagues that we hadn't seen in a long time, network, and listen to some really great speakers. And I am going to hand it over to Eve, our practice manager at Healing Wings, to talk about the other points.
Thank you. So my name is Eve Asileme, and I'm the practice manager here at JPS, the Healing Wings Clinic in Fort Worth. Hey, Michael. If you can go back to the previous slide. We're still on that slide. So yeah, so other communications we have with our other subrecipients is that we do establish monthly meetings with our other agencies in the area. So our AIDS Outreach Center, we have monthly meetings. Before COVID, we used to meet in person, but now they kind of meet when necessary to go over the shared clients that we have, especially if we have clients that we need outreach, we need assistance with, you know, they got released from jail, we need any type of communication like that. And so we do have monthly meetings with all our other agencies that we work with. And then also here, what's listed here are oral health meetings. So since JPS, we also provide oral health services. We also have other agencies that provide the same services as well. And so we really do collaborate well to ensure, A, we're not duplicating work, but also see how we can leverage each other's strengths. Like if we are behind in our schedule, we can reach out to our subrecipients and see like, hey, can we send this client over to you? And also let our clients know that there's other resources in the area that they may live closer to, if they live in a different part of Tarrant County that might be better suitable for them. And so we work with them and with other agencies as well to connect those clients appropriately. If we'll go to the next slide, thank you. And then our referrals and provide enterprise. As Caitlin mentioned earlier, we do use a system called Provide Enterprise. And so with the new release of TCT, Provide Enterprise is really a software module to where all of our agencies who are recipients of Ryan White, we're able to submit referrals to each other. So like, for instance, our monthly meetings that we have with AOC, we can submit an outreach referral to that agency, and then we can see if that agency received the referral by providing status updates on the referral. So it's a very good system to kind of streamline a lot of the processes that we have and making sure clients are getting connected. And also patients don't have to submit documents every time they come to a new agency. This is like a storehouse. So all their eligibility requirements are in this software, and we can pull them and also help them, you know, and for anything that they need related to Ryan White. So it's a really nice system that we have. We use Epic, and so we can import like lab values. They kept their appointments into this into Provide as well. So it can be shared around across other agencies that they need. So it's a very, very good referral system that we have. And then I do want to briefly talk about some of the initiatives that we have with Rapid Start. So here at JPS Healing Wings, or really JPS, we are working and establishing our own Rapid Start program here. We kind of have like two pathways. We're working with our emergency department for them to offer Rapid Start, as well as creating another line to where we can initiate Rapid Start in our clinic. So more to come for that. But I just want to give you some updates too as what we're doing here at JPS.
Thank you so much, Eve. I appreciate that. And now I know we only have about 4 minutes, so I'll turn it over to Grace and Anna Yensi with CAN Community Health to talk a little bit about their agency.
Awesome. Thank you so much, Caitlin. My name is Grace Ashu. I am the Regional Director of HIV and Prevention for the West Coast. So I actually oversee the prevention services when it comes to testing and education. I'm very excited to be here today to talk a little bit about CAN. If you don't know much about CAN, we stand for Community AIDS Network, and we've actually been caring for people living with HIV for over 30 years. We've been a Tarrant County Ryan White subrecipient for over a year now, and I'm very excited to talk about our services, but I'll pass it over to Anna Yancy to introduce herself.
Good morning, everyone. Thank you all for having us here. As Grace mentioned, I'm Anna Yensi, and I'm the current program manager for our Arlington, Texas operations.
Awesome. And so we are going to talk about our quality improvement methods and also our rapid start process. So when we come down to it, CAN really focuses on being patient-centered. So we really want to be able to link that patient to a great continuum of care. So what we do is we utilize early intervention and case management services in order to ensure necessary services and support for those living with HIV. So we utilize our early intervention specialists as well as our case management services to allow for those CAN clients and patients to receive assessments, additional referral resources to other Ryan White subrecipients and other external organizations. So when it comes to that, we not only do it internally, but we also refer externally. And what we've done so far is successfully creating a relationship of referrals between external subrecipients to increase dental, medical, and prevention services. So to kind of give you a little bit of what NANC does is community engagement. So we have a large partnership with AOC and HELP in order to create referral systems for testing services at CAN. And then we'll also talk about our rapid start system through Tarrant County and other agencies. And on top of what we do with that is community engagement. So when we talk about community engagement, that's actually partnering with non-funded partnerships. So something like Legacy Cares, which I know Melissa Grove is in the chat today or in the meeting, that's something that's pretty big for us to do over the past 5 months, and also with LGBTQ Saves. And then I'll also let NANC highlight a little bit more about our challenges when it comes to Provide Enterprise, because that is actually a system that we utilize to receive our referrals from other subrecipients and also refer externally as well, and some of those challenges that we have seen.
Sorry, everyone, mute button issues. So just to kind of, we've touched a lot about Provide Enterprise, and it is great for everyone that has access to that system. It does get a little bit tricky when we are trying to refer people out. And then additionally, we also have gotten a lot of feedback from just different organizations that unless someone is consistently working in the system, it can be a little bit overwhelming and or confusing. And so we really like to ensure that in order to alleviate some of these issues, that we also provide them with a warm kind of handoff with putting names to faces and actually starting to create and build those relationships between one another, not just as agencies, but truly as staff members of these agencies. So luckily, creating kind of personal relationships and being able to do warm handoffs in combination with the Provide Enterprise referral system, that has been extremely well and has worked out for us as well.
Yeah. And when it comes to that, another challenge point that we've seen is saturation of services. So as you guys know, we're all kind of in the same space doing similar services within Tarrant County. So having multiple subrecipients in an area at times is a great thing, but at times can be very challenging when it comes to reluctancy to refer or creating hurdles when it comes to patients receiving care. So those were a few of the successes that we've seen, as well as the challenges. But what we've kind of taken when it comes to quality improvement is really implementing new methods to make sure that we're connecting those patients to care and making sure that we're reducing those barriers. Caitlin, if you don't mind going to the next slide, I'll talk about our rapid start process.
Yeah,
So
I'm sorry to jump in, but we only have about 1 minute left before you have to switch over.
Okay, no problem. I'll make it fast. So through our rapid start services, we actually want to link patients same day or within 72 hours. So we actually have about 3 types of staff members that are very important and instrumental to our rapid start process. So we do use EIS specialists who do the job of making sure that patient is linked to care and doing that continuum of care. And then we also have case managers that do follow-up support services and provide monthly check-ins on a monthly basis. Patient navigators also do social services support. So outside of just in general getting that education linkage to care, they also do engagement, retention, and re-engagement and treatment. Next slide, please. And so just to kind of give you guys a little bit more of background on the data that we've seen and how we work with other Ryan White subrecipients, we did place a data chart. Caitlin, if you don't mind going to the next slide, sorry. We did receive or place in a data chart, which is basically a summary of our overall new HIV positives and test and treat. So as you see in the highlighted sections on the left, we only did about 3 months out, just to kind of give you guys a big picture. From the health department, we did receive about 10 total. So being able to get those referrals from Tarrant County, and then from other AIDS organizations, we did receive 2 in the past 4 months. So in total, 12. So being able to really create those partnerships is very major to us. And then on the right-hand side is a summary of our new HIV rapid starts received by Ryan White subrecipients specifically. So the health department did have about 9 at 25%, and the AIDS service organizations had about 2 at 5%. There are some discrepancies as we didn't pull fully all the data when it comes to external referrals, when it comes to utilizing Provide Enterprise, but this is the raw data that we wanted to present to you guys today. Caitlin, if you don't mind going to the next slide as well, we'll kind of give you guys a roundabout of how we utilize Provide Enterprise to do outgoing referrals as well. So not only do we do internal, we also do external. So our case manager, Jennings and Alejandra, have the job of utilizing Provide Enterprise to send out those referrals for any patient who has barriers to care or has any need for external resources. And as you can see, the highest needs would be housing, would be mental health, and then also it would be support services. So those are definitely needs that patients have within Tarrant County, and we want to make sure that we ensure that continuum of care. A little bit more about this data is the fact that we also do internal referrals over to our dental team, over to our medical team. So those weren't accounted for when it comes to outgoing, but we do internal. So that kind of gives you guys a little bit of a roundabout of our canned services. If you have any questions about how we've implemented our rapid start process, and Nancy and I would love to discuss more, but just to kind of give you guys an overall scope, that's mostly what we do here at CAN. Thank you.
Thank you so much. And yes, I think that we need to move on to our next presenters.
You muted yourself, Michael.
That's something that I tend to do, technology woes, right? Sorry about that. I was asking, do we need to move on to the next presenter? And maybe if folks have questions, they can put it in the chat room.
Mm-hmm. Yeah, I'll actually, I'll kick it over. Dhruvi, Amelia, and Miranda, we want to hear from you, so I'll turn it over.
Great, thank you so much, Jamie. Hi, everyone. My name is Dhruvi Chauhan, and my pronouns are she, her, hers. And I am a technical assistance coach for Tap In at CAI. Tap In stands for Technical Assistance Provider Innovation Network, and we're funded by HRSA Hub to provide technical assistance to EHE-funded jurisdictions implementing treatment and care strategies. And we're really happy to be here today to talk about the cultural humility technical assistance and training that we're supporting Dallas County in. I'm going to hand it over to my colleague Amelia to introduce herself.
Hi, everyone. My name is Amelia Gonzalez, she, her pronouns. I am the Technical Assistance Regional Lead on the Tap-In team, and I work with EHE-funded jurisdictions in the West region. And it's really great to be here today and also to see some familiar faces from Tarrant County. Hi, Caitlin. And so we're really excited to jump into this quick overview of how we're thinking about providing cultural humility training in Dallas County. So I will pass it back to Dhruvi.
Awesome, thank you. So today, as Amelia said, we're just going to have a little bit of time with this group today to discuss the cultural humility in HIV care training that our TA team is planning to develop and implement in collaboration with and in alignment with the goals of Dallas County's strategies to end the HIV epidemic. So we'll spend some time briefly outlining how cultural humility connects with the broader goals in Dallas County and what this training development process might look like, and then get your feedback and thoughts on the plans as well. So I will hand it off to Miranda to discuss this next slide, actually.
Good morning, everyone. Thank you guys for being here. Just to give a little bit of a background, in terms of the EHE strategy, we know that the goal is a 90% reduction in new HIV diagnoses in Dallas County, going from 830 to 83. So we've got a journey ahead of us, but we definitely want to respond with action and using community feedback as our base. And we do know that cultural humility, which has been a theme throughout this call and comes all the way from NHOS and right down here to Dallas. It's a common thread. And as we're talking about the return to care process, we're definitely looking at root causes, barriers to entry, and opportunities to re-enter into care. So ultimately the goal and rationale for this training is really to build the capacity of our systems. And so if we can go to the next slide. So, HRSA comes and does its site visit. And, these are just a couple of the comments that came when HRSA did do their interviews with some of our consumers. And they really talked into the need for cultural competency and compassion, especially with primary care and linkage services. And then clients really wanted to feel empowered and meaningfully involved in their own care. And clients were also experiencing challenges in navigating the different systems in care. And so, and the final thought was, a focus on a need for population-specific services and not just, generalized care for all. And I will go ahead and pass it on to our next presenter.
Great, thank you, Miranda. Thanks for providing a little bit of context about the background and rationale for this training, and especially as Jamie just shouted out in the chat, what the community was, the feedback the community gave. And so we've been working with Dallas County to think about what the goals for this training and TA could be and how it can align with the goals of return to care as well. And so we're hoping that as an outcome of this training and TA, some of the outcomes we'll see include that we will be able to build provider level skills and knowledge around culturally humble HIV care. We want to enhance and build on the current knowledge of providers. We know that there's a variance of expertise already on this topic, and we want to have a space where we can enhance and build that knowledge as a community. We want to build capacity providers to support and care for clients from Dallas County's priority populations, which includes MSM, Black men and Black women, and of course the other priority populations that your agencies are working with, and to build the case for system change and investment to address root causes of lack of retention and care. So we know that this training definitely is to be combined with looking at, and is just a starting place to look at, what other system changes need to happen and what kind of needs to come with this foundation of a training for providers. Next slide, please. And so we know that this is an activity that Dallas County wants to implement to build the capacity of the system of care to serve the most vulnerable populations and as a response to community feedback. Why start with cultural humility? So we know that cultural humility was talked about a little bit today on the call already. And we know again that people have various levels of expertise already on this subject. And it is really just the practice of caring for one's patients based on self-reflexivity and assessment, and having an appreciation for patients' expertise on the social and cultural context of their lives, and openness to establishing power balanced relationships with patients, and a lifelong dedication to learning. And so really understanding that this training will set a standard for an approach to client care that emphasizes clients as experts in their own lives and acknowledges the power dynamic in play for clients as they enter the system, as well as understanding that cultural humility is a lifelong commitment and a lifelong learning process will be a really important way to ensure that clients are receiving care in ways that lead to retention and care. So that's why we're starting with cultural humility, and hoping to tailor this training for you all, for all your providers. Next slide, please. And just to really give a quick overview of our plan that's still in development. These are a couple of our key steps in TA and the development of this training. So our next step really is to implement a survey for providers. We want to identify providers' needs when it comes to this training and to understand what topics and areas could be most useful for them, what could make this training valuable for them. We want to make sure this series is tailored to their needs. And we also want to understand what are those needs for longer term system change work through this survey, and asking questions about organizational culture, practice, things like that. And we know that this survey is a way for providers to give us their input and inform the scope of the training. So we know it'll be really important to have providers take this survey, help us customize this training, make sure it's interactive and engaging. And then our next step is definitely to get community feedback. We know it's imperative to get feedback from the community on this training as it's developed, and we're looking forward to hearing your thoughts later on how we could potentially do this in the future. And then after that, of course, we'll deliver the training, which Amelia will go into more detail on the next slide. And following that, as we've been saying, we want this training to set the stage for other systems change strategies to complement this training. And that will really be our ultimate step and our next steps after the training. So with that, I'll hand it off to Amelia for the next slide.
Thanks, Dhruvi. So as Dhruvi said, I'll talk a little bit more about some of those steps that Dhruvi mentioned in the previous slide. And so like she said, our first step is really like in this planning phase to really get some feedback from providers. So of course, we want to disseminate a provider survey, and we'll be asking questions to really get a better understanding of the challenges providers are facing in providing client-centered care, and to really understand what our training could focus on, what capacity could be built within the organizations to transform approaches to client-centered care and cultural humility. So that is part of the first step. And then the other piece of this is that we really want to get feedback from the community or consumers. So we're planning to do that to further inform the design of the training and allow us to think about the other system changes that are needed in order to respond to what we're hearing from consumers. And so what we hear from consumers will kind of inform how we design the training, because we really want that voice to be the center of this training. So we're thinking about ways to bring in the community or consumer voice. And we will ask you a question about that in one of the next slides. So just keep that in mind. And then based on what we hear from the provider survey and community or consumer feedback, we'll then design a series of sessions that speak to what's emerged from that first phase of gathering some data and information. So, we're not completely sure, what that series is going to look like, because we're waiting to get that information. And then the training will really be a requirement for anyone that's in a role that's funded with EHE dollars in Dallas County. So when we talk about providers, we really mean anyone that's providing care, not just clinicians, could be other service providers, but anyone that's funded with EHE dollars. So we just wanted to give an overview of what that's shaping up to look like. And then in the next slide, if we can go to the next slide, Dhruvi, we had a couple of questions for you. So we wanted to hear from this group just some initial impressions, what your initial thoughts on this plan to move towards strengthening cultural humility among Dallas County care providers. What are your initial thoughts on that? What are your initial thoughts on the training series generally? And then, as I was mentioning before, we really want to hear from you about, how do we go about getting community feedback on this training content as we're developing it? So feel free to answer any of those questions if you want to come off mute or put things in the chat, whatever works for you all. But this is a really great opportunity for us to hear more from you as we're moving forward with the plans for this cultural humility training. So I will be quiet and see what others have to say.
Thanks, Amelia. I think this is really exciting to know that there's more coming down the pike. We've put the questions in the chat. We're going to definitely keep the chat and follow up and provide that later, since there's been some great activity. I am, maybe for the sake of time, we just encourage folks to utilize the chat and know more is coming soon to continue to sort of assess and see what they need. We have just a couple of quick reminders. We're going to cruise through super fast, and we'll share your information if folks have questions. So as a reminder to our subs, we have Action Plan 7. There are some example guiding questions to assist you, and also plenty of room for you to write what you identify as key critical steps. Reminder, these action plans are important in helping us continue to develop the series. We can move on to the next slide. We'll table discussion for today, but we are available for one-on-one agency TA throughout this period. Reminder, August and October, we have 2 more sessions, and in December, our poster presentation. I'm going to turn it over. I think we're here to do a little bit of evaluation. I want to, again, give the biggest shout out to all of our speakers. So folks, if you could, in the remaining few moments, let us know how this went today. We have this webinar and discussion met my expectations with the scale from strongly agree, agree, neutral, disagree, or strongly disagree. Once you've done that, we also want to know, how about the duration? We are packing a lot into this, so let's be real. We don't want to go too long, too short. Where's our Goldilocks just right? So let us know if the duration, how you feel about that. The opportunities to share or participate in the webinar, looking for too few, just right, or too many. And then again, let's check in on the content. Is the content provided in the webinar just right, too little, too much? These sessions are designed for you and designed to support your action planning and your QIP implementation. So your feedback is critical. We've got about 13 of 26 responses. So we'll let folks know. Again, we have the toolkit, the slides, and more resources and information, as well as sharing contact information. We appreciate all of our speakers, their transparency and their support and their openness to communicate with us. So with that, if you've responded, do we want to publish the poll? Okay, cool. All right, so we will take this into consideration in terms of meeting expectations, the link, opportunities for involvement, as well as content provided. You all are outstanding. Thank you again to our speakers. Thank you to Sonia and Oscar for your leadership and the team. Have a fantastic day, and we will see you all soon.
Absolutely. And if anyone does want to stick around and chat a little bit, there's no pressure. The program is over. We're going to stop the recording. But if folks do want to kind of hang out in the room and chat, you know, we're definitely open to that as well. Thank you again to, just to reiterate what other folks have said, thank you to our guest speakers. They were all really great in terms of helping us to see what possibilities we have, you know, for the cultural humility piece. I don't think that we emphasized it, but remember at the January poster presentation, for all of our different aspects that we're trying to work on, creating a stigma-free environment was blank. You know, we had lots of activities for our other elements that we're interested in working on, but we didn't have anything for that. So it's great to know that this project through TAPIN and EHE really is starting to help address that. And that'll go a long way in our field for our folks, both for you and for the community of people that we serve. So I can stop the recording, and if, you know, folks have any comments or, you know, reactions that they'd like to share, if you're still on the line, please do so.